Okay, Siva?
Hi, Neil. Can you see me?
Neil here with, and yeah, I can see and hear you very clearly. I'm here with Henry and Samir and Max. Welcome.
Thank you very much. And I'm sure, Neil, you will have a lot of nostalgia when you see this unit. This was the unit which you had visited so often, and you have done so many interventions in the same place. And hi to Henry Justino and Samir Ghafoor. We have the third patient of today. Can I request my colleague to give the PowerPoint presentation?
Good morning, all. We have 76 years old.
Can you hear the audio, Neil?
76 years old male, non-hypertensive, non-diabetic.
Choice of black lettering on a blue background.
Was diagnosed to have severe aortic regurgitation during evaluation for breathlessness on exertion in January 2016 and subsequently underwent aortic wall replacement with St. Jude mechanical bileaflet prosthetic wall. Thereafter, he was apparently well for next 1.5 years and subsequently started to have breathlessness on exertion, NYHA class 2 since last 1 year. Presently, he is on ivabradine, furosemide, aldactone and tablet warfarin. On examination, he weighs 64 kgs, pulse rate is 70 per minute regular, BP is 130 by 80 millimeters of mercury, saturation is 98%. On cardiovascular system examination, first heart sound is normal, there is prosthetic wall click is heard well, there is early diastolic murmur grade 3 by 4 at aortic area and systolic murmur of grade 3 by 6 at left upper sternal border. X-ray shows situs solutus levocardia, CTR of 55%, sternal wise seen moderate pulmonary venous hypertension with perihilar haze. ECG shows sinus rhythm with ventricular rate of 75 per minute. QRS axis is negative 45 degrees. PR interval of 140 milliseconds. Echo shows well functioning aortic prosthetics. There is severe paravalvular leak with mild MR. Paravalvular leak area measured 10 millimeter on the echo. CT aortogram done revealed normal epicardial coronaries. There was severe paravalvular leak in the anteromedial region near the tricuspid wall. It measured around 7 by 3 millimeter on the CT. So final diagnosis status post aortic wall replacement, well functioning aortic prosthesis with no significant gradient. Severe aortic paravalvular leak in the anteromedial region of the aortic annulus, mild MR with good biventricular function, and plan is prosthetic aortic paravalvular leak device closure.
Hello.
Excellent. Sounds like a good plan.
Yeah. Neil, I have with me Dr. Ramya Shri, who is my colleague, who is assisting me with the procedure, and Dr. Uma Mageshwar, who is guiding me with the imaging. The scheduled procedure is aortic paravalvular leak device closure. We thought that being an elderly man, we will try to avoid a transesophageal echocardiography. Not that the transesophageal echo showed us great pictures, because of the lot of calcification around the aortic root, lot of calcification around the mitral annulus. The pictures were not very great. Go to fluoroscopy live. I can show the fluoroscopy. Fluoroscopy big. Fluoroscopy big. Fluoroscopy big. Hello. Okay, you can appreciate that there is a lot of calcification on the mitral annular area, even though we are not seeing too much of calcification. Run this fluoroscopy. So we made an angiography. The aortic pressures were 145 by 50. There was a pulse pressure of 95 millimeters of mercury. The prosthetic valve disc movements were normal. We could see Seller's grade 3 aortic regurgitation. The prosthetic disc movements were normal. From the venous side, we did a right heart hemodynamics, and the pulmonary artery pressures were marginally elevated. It was around 36 millimeters systolic with around 26 mean. The coronary arteries were patent on the CT, and so we did not do a selective coronary shoot, but this aortic root shows both the right coronary and the left coronary were normal. Left circumflex was dominant and the right coronary was non-dominant. This particular projection did not show the profile the leak well. Next picture. So we increased the LAO angulation, and here we could see, freeze it. Yeah, just go to the next frame. Yeah, just freeze, go back. Yeah, we could see that on the side of the prosthetic ring, we're able to see the leak. Can you see the pictures clearly, Dr. Neil, there?
We can see the pictures clearly, but you're going to need to point out where you think the paravalve leak is. Is it, as we look at it, on the left?
It's on the left side of the screen. Yeah, left.
Towards the septal side of the
Just below the right coronary artery.
left of the screen, so on the septal side of the...
On the septal side. Yeah, it was facing the tricuspid valve,
okay, gotcha.
and it is on the just below the right coronary artery. And then actually we started the procedure a little earlier, and so instead of waiting a lot, we crossed the leak. Next picture. So this was the J termo angled termo glide wire, which is entering into the left ventricle in the same projection, and we advanced. This is it's just a guide wire alone. This is an angled. Yes.
We didn't have a catheter supporting that.
It was there. It is just not seen because we are focusing only on the valve. It's a Judkins right catheter which was on the top.
Yes.
But Judkins right. Judkins right 5 French catheter. And then we cross the valve. Next, we put in a superstiff wire, and this is a 6 French long flexor shuttle sheath. Next, and the shuttle sheath is entering into the left ventricle. Next, and now can you show the hemodynamics? The sheath has not. The sheath has not.
Just quickly, you're going through.
Yeah, Dr. Samir.
Yeah, so you're going through some steps which are pretty important here. Yeah, so I think first of all, you're noticing that the prosthetic leaflets are moving very freely all the way through. Did you notice any problems in terms of advancing the 6 French shuttle sheath, any resistance, anything else that would have made you change your strategy or anything like that? It seems very straightforward, but these are very important steps for this type of procedure.
Yeah, on a CT scan, when we were measuring the leak, it was measuring around 7 millimeter in the long axis, and it was measuring around 2.6 millimeter in the short axis. Since 6 French shuttle sheath's outer dimension will be a little more than 3 millimeter, there was a little bit of resistance. However, being a hydrophilic flexor sheath, it just walked in. I would say maybe a very subtle resistance that I had in that area. And what is seen, you can also notice that we have...
Siva, stop talking. Henry wants to say something.
Yeah.
Justino, any concerns about conduction abnormality? Did you see a left bundle develop?
No. It is the PR interval is normal, and the QRS is remaining smaller, is narrower. No differences after my sheath.
Siva, you're doing a great job. But we want to interact. Mansoor Al-Jafan was up the top there from Riyadh. Mansoor? Are you there?
Hi, Mansoor. Nice to hear you.
Okay, I don't see you.
Hi, Shiva. Good work, very daring. What do you want me to say?
So we have a 7 by 2.5 millimeter leak. What device would you favor in Riyadh?
It is 7 millimeter into 3 millimeter. It's a oval leak with 7 millimeter in the long axis and 3 in the short axis.
I have no idea. I will just ask for the catalog and look at them, and probably upper size it by maybe 50, 40%, because invariably those leaks are very irregular, and they, the room inferiorly and superiorly are very accommodating to the extra size, and almost always you will be left with residual leaks.
Okay, good point. I agree with your last comment. Gianfranco, and then who's that below? Daniel.
Hello, Gianfranco from Milan.
Hi, Gianfranco.
I do have a comment. Usually in those cases, hello, nice to see you. I do perform a kind of balloon sizing with an angioplasty balloon, but without any pressure inside it, in order to repeat the angiography, in order to, understand about the compliance of the tissue and to rule out any further defects around it.
Yeah, I agree, Gianfranco. That's a good strategy, especially when the aortic annulus is densely calcified and you don't get good echocardiographic images. I also do that. Take a small 6 millimeter or 7 millimeter Ty-Shak 2 balloon, inflate it at very low pressure, and try to see whether there is a waste. Yeah, I also do that. But in this patient, the CT was giving a dimension of 7:3.
We have 2 more questions for you.
Yeah.
And also, it could be also useful to understand about the morphology of the defect itself, if it is tunnel-like or a small penetration.
Okay, we got that. Matt? Daniel?
So, looking at this thing, it's slightly asymmetric. I think we'd be thinking of an oblong type device, probably the AVP3, and I kind of go 10-5, but it would be influenced a lot on how the catheter crossed the lesion. You can get that through a 5 French delivery system, so that would have been my, default looking at the CT.
Thank you. And one more comment, is that Nick?
This is Nick. Hi, greeting to India. What about an Oclotec parallel leak device? It has this oval shape, has disc on both sides, and is designed for defects like this.
Yeah.
Does it go through a 6 French sheath?
Whatever sheath it takes.
Yeah, we considered both Amplatzer vascular plug 3, which is a rectangular device. Hello. Yeah, we considered
Did you
both.
say AVP?
No.
3?
Yeah, we are currently we are going with the AVP2.
That's not an AVP3 that you were showing us.
This is AVP2. We considered both AVP3 as well as an Oclotec paravalvular leak device, both of which will need a 7 French sheath, but we thought we will go, this is not one of the very large leaks. And so we decided that an Amplatzer vascular plug 10 millimeter should be able to stent out the 7 millimeter longer dimension. So when I am withdrawing partially, if I can get the belly of this middle lobe across the leak, I think that should be doing the job. If it had been a little larger defect, definitely a rectangular type of Oclotec paravalvular leak device or an AVP3.
Keep going.
Yeah. So right now, let me also show the hemodynamics.
Carry on.
Show the pressures. Show the pressures. So the left ventricular pressure is about 180. We had an aortic pressure of close to 150. So, but these were at 2 different times, and so it is likely that there may be a minimal, maybe around 20 gradient or so. Even though on echo we did not find a gradient, we don't have an idea about what was the size of the valve because the patient comes from Malaysia and we don't have the surgical notes. So right now I'm going to withdraw the pictile that is within the left ventricle, within the sheath, and now we are going to be getting ready for deploying the device. We have checked the ACT, and ACT is more than 300 at present. We have given the normal dose of 100 units per kg unfractionated heparin. So what we are planning to do use is a 10 millimeter AVP2 device, which is I think in most part of US the regular workhorse device for a paravalvular leak. Neil?
Yeah, I think that's reasonable. And Nick, I think, made a reasonable suggestion there. It sounds like, though, your choice is based on the fact that you've got a 6 French shuttle sheath across there, Nick. So sounded like your device needed a 7. So fair enough. Seems reasonable.
Yeah. So right now we are coming out with the device. So I'm allowing the LV lobe to open out fully. I'm partially opening out the middle lobe.
Eva?
Yes?
Eva?
Yep.
Eva? Is there any way you can is there any way you can tell from an intracardiac echo whether your device is opening near the mitral chordae or not? It's difficult with all that calcium, I agree, but I'm just asking.
So Neil, we are not getting great pictures on the intracardiac echo because of lots of calcification that are coming in between.
Understood. There, I do just wonder if you were stuck on some mitral valve apparatus.
Give a forward push, Ramya. Okay. Leave it.
What do you want to see me?
The leaflets are moving or not. I think they are, but
Can you get me the view where we saw the leaflets?
3322.
Fully go to that same view and magnify this view.
Yep. John.
Okay. Give a comment from...
Siva,
Yes.
can you hear me?
Yeah, I'm hearing you.
It's John Thompson here. Siva, what's your experience? What's your experience of hemolysis in these extremely calcified lesions?
I have seen it more often with mitral, John, not too often with aortics. Mitrals are notorious to produce a lot of leak. I think probably reason is there is a lot of pressure gradient between the LV and LA. But maybe the diastolic pressure gradient between aorta and LV is not so high. I have not seen two. Can you get it much more sharper? Get a proper angle so that I see the leak. Yeah, perfect. Perfect.
Well,
now make the ring become flat.
one leaflet is not moving.
Is it so?
there's a comment about restricted opening of the left leaflet.
Show that
as
last
we
floor,
look at
last
it.
acquisition. Last acquisition. No, last acquisition. Can you show the previous, the first acquisition?
And the other thing,
Just with the sheath.
if you would release
With the
this,
sheath,
the
yeah.
upper part would come down a little bit
that
more,
one.
wouldn't it?
Magnify
and there's
this.
maybe another problem with the leaflets.
Yeah, I agree. It doesn't look good now, so I will try to reposition it a little bit, push the lobe a little more deeper. Show this last picture. Last picture. Yeah, I agree. So right now, go to the same view.
Dr. Lorber, Avram Lorber's up there somewhere. Avram, any tips for
Hold
this?
it
Please
tight.
go to a microphone. Any tips to overcome this problem? Be quick now.
Okay, relax.
Somebody help me with the
Get on to the same fluoroscopic projection. Get to the
And the
same angle.
autogram could show us the way the leaflets move.
Same angle. The previous.
Well, we think we can see the leaflets on this projection.
No, 32.
Get on to the same view. You remember the number? And then
33, 22.
Sivakumar,
25 and 10. 25 and 10.
quickly, can you show us pressure? Or can you show us pressure while you are working?
Yeah, it is definitely low. So
Pressure and show us.
May I make a comment, Gianfranco Butera from Milan?
Yes, please,
Yeah.
Franco. From where did you say?
From Frankfurt. No, my point is that in those cases I do prefer to upsize a bit the introducer and leave a body wire in order to, make it easier to re-enter and also to fine-tune
I'm
the
trying to
position
recapture.
while they're implanting the device. And
Okay, Siva, did you hear that suggestion? bit late now. We'll let you wrestle with that. Dr. Calvert was just to make a comment.
Just a comment at this moment in time. Can you see that the sheath is across the device is not light and it was still restricted? So this is probably quite small. So you need to downsize considerably in your device size. For us, the imaging is extremely important to deciding. You need to understand the anatomy, the shape of the hole, is it trapezius,
I'll try to...
its size, its entry, its exit, and I just don't feel I have that from the eyes.
I think we'd agree now that those valve leaflets are parallel.
Sure, but as the sheath is going across at the start, there's still restrictions.
What shall we do, Neil? What shall I try to deploy at a little lower level? What's your suggestion?
I think it's the wrong device.
Well, Dr. Calvert, listen. Dr. Calvert thinks it's a wrong device. You need a smaller device. I personally think, well, you've got a device there. It's worth trying another configuration. Oh.
How many people in the audience would be using a AVP3 device here? Raise your hand. How many people in the audience would be using the Occlutech paravalvular leak occluder device? Raise your hand. So a little bit less, but still gaining more in that.
Can you go to that? Okay. No, let it be there. Let it be there.
And,
Yeah.
sorry. Number 4. So do you want to come to a mic and say what you're saying? We'll make sure people hear. AVP4. What size AVP4? 6 millimeter AVP4. Are you worried that you would get full closure with the AVP4? It's a bit smaller compared to the other size devices that people have been mentioning.
Hold it.
Thank you. Siva, can you hear us now? Siva? Don't think you can hear us.
I think we've seen now 2 times whenever he opens this distal disc and pulls it back,
yes.
the distal disc impairs the function, whatever the rest of the device does. So he has to use something with less disc, let's put it like this.
So what would you use, Nick?
Occlutech occluder.
Hello, can you...
And if it's an oval shape, you have...
Neil, I was not able to hear you for a lot of time. Are you able to hear something now? I lost the audio for a long time.
We can hear you clearly.
Okay. Neil, the problem that
We can hear you clearly. Can you hear me?
Yeah, now, right now well. See, the problem...
Can you hear me?
I'm able to hear you very well.
Can you hear me?
Yes.
Good. The suggestion is a smaller device.
Okay.
One suggestion is to use an Occlutech paravalve leak device, but did you say which size, Nick?
I didn't get the exact measurements of the hole, so...
7 by 3.
7 by 3.
Approximately.
You have these with the twisted device. I would use one of the twisted devices, and oops, it's out. And then I have to look it up. I don't know exactly. I have to check.
Fine.
May I make a suggestion?
Yes, Raphael.
I would replace this device with 2 AVP2s, 4 and 6, and exteriorize them simultaneously from the sheet and pull them back.
Okay, understood. Okay, Siva, what's your plan?
My plan was to, as you were suggesting, to go for a smaller device. Now, one of the problems that I am facing is the left ventricular disc is coming in the way of the housing. So, I am thinking about using an AVP 4 8 millimeter, the largest AVP 4 device. What do you feel?
Okay, that's reasonable. I think Z was suggesting 6 millimeter, but if you want 8. Now, is there anybody here from Oslotech?
Z, is it
and
6
verse on the
millimeter
size of a-
AVP2 or AVP4? Is he around?
AVP4 he was advocating.
Okay, AVP4 I was thinking about.
He's left, but it was AVP4
8
he
mm.
was advocating.
Okay.
Well, if he's still there. Try and use a microphone, could you?
So I'm taking the AVP4 now. It's a 8 millimeter. It's the largest size AVP4.
Siva, yeah, I would, your leak is pretty small because the sheet is 6 French and it's basically, it looks like it's occluding the leak. I would start with a 6 millimeter AVP4. I think that should definitely, it's tapered at the tip of it, so it should not interfere with the prosthetic valve leaflets. The Oculotech is a good device. The problem is, either the square or the rectangular, they will interfere with this valve leaflets. I've seen some cases with the prosthetic valves where the disc does interfere with that. I prefer the Oculotech for the paravalvular mitral leaks. I use that almost exclusively.
Yeah, I have used Oculotech rectangular paravalvular leak 2 times in aortic position, but those leaks were larger. Here, this is not one of those very large leaks. So right now, Z, what in view of the dimension of 7 millimeter that I got on the long axis, I am tempted to go for 8 mm AVP4.
Okay, Shiva, good luck with this. We're with you.
Yeah. So I'm the previous flexor sheath I had a 2 boost. So right now, since the AVP4 comes with its own delivery system, I have connected that, and now.
But Shiva, you could also, following Gianfranco's suggestion, have a body wire there and still comfortably get a 6 millimeter AVP.
Show me below. Show me below.
Your 6 French shuttle sheet.
The sheet, please, Brian.
Body wire means 1/8 wire because
1/4, I think, currently. Yeah.
Okay. See now. Let me
Hopefully
go
you
back
won't
to
see
that
this.
view, the view in which we saw the leak. No, the view in which we saw the leak, it was steeper level. Yeah. Yeah, make it larger. Yeah. So I will compact this device a little bit. Go back to that, the view in which we saw the 2510, I think. This looks better. Magnify. Magnify. Zoom it. See, it looks fine. Dr. Raphael was mentioning, actually he was identifying the restriction of the mobility. It was caused by the wide LV disc. Right now, the LV disc has become a small carrot. Neil, are you hearing me?
I can hear you very clearly.
Okay. I am losing the audio from your end.
I do think you can't always I'm just saying, whichever device you use, you can't always predict how it's going to conform after release, because there you obviously have some tension on the aortic side of the device, don't you? And just don't know how it's going to configure when you release. But we're with you.
So I'm making an injection through the side arm of the sheath. It's not working because the valve.
Daniel DeWolf, there somewhere. Daniel. Ready to release?
No, I didn't make an angiogram. I'll make an angiogram
Well,
and then
Uh,
give the 2 boost.
I would push my sheet a little bit forward, but for the rest, I'm pretty confident that this will work.
Okay, good. And Paddy, then?
Just to add to that comment, I always try and push the disc down a little bit just to see if it interferes. To
Yeah.
try and, I agree, Neil, it's difficult to predict, but you can try and sort of provoke an interruption, and then you know you've got a problem.
Okay, so the suggestion, Siva, from Dr. DeWolf and Dr. Calvert is that you push the delivery sheath down a little bit to see if you can constitute the aortic disc a little more and see if that changes the interference.
It is looking good now, Neil.
Yeah, we agree.
This is contrast.
What is the angiogram going to tell you?
Go to that same projection where we got the leak originally. It's going to take some time for the closure. However, we are just looking at the how much of the distal lobe is below the anal. We can see the foaming of the whole of the disc. So I'm happy here. So I'm going to release it. What do you say, Neil? Get back to the same view where the disc was seen.
Shiva?
Yes.
Do you think the leak is broader and extends almost to the left coronary? Seems to encompass almost the entire annulus.
No. Actually, we have done.
Unless you think that's going through the leaflets, can you tell by ice?
Actually, ice is not helping at all because of the dense some sort of a calcification around. We are not getting any pictures at all on the ice. It is not profiling anything. I can release the device and then put in a proper pigtail and give an angio. However, I'm afraid the device is going to take some time to form some fibrin inside.
Any change in diastolic blood pressure of this patient?
I will show you now. I had
Maybe
one.
you can try TPE.
I didn't hear that.
Try doing transthoracic echo. It's important to see the leak on echo.
Yeah.
Angio is not really helpful.
Yeah. So can you get a transthoracic echo, Uma? Show me the aortic pressure.
Open the aortic pressure, please.
Show the aortic pressure bigger in an yellow color. The red is not visible. Change the color to yellow. Make the hemodynamics bigger.
While he's doing that, I'm looking at the Occlutech sizing chart, and it's going for 8x4 rims. The rims go up to 14x10. So I agree with the thought process that Occlutech could have been considered, but the rims would have probably been too large in the
So we have an aortic pressure of something like 150 on.
Yeah, it is still
60,
still about
we
90.
Can't remember what it was before. But
It was close to 95, and now it is 90. It's almost.
Yeah, your pulse pressure is about the same, isn't it?
Yes, exactly.
Which is no surprise, really.
Yeah, make the echo bigger.
So, what do you think? Another device?
No.
Or come back another time.
No, I think we have to wait for some time for some thrombus to form on this device. This device is without any fabric. When we have put this device in coronary fistulas and all, it used to flow for 1 month, and then only stop. So it's a device that takes a long time to close. The AVP2 probably is a better device.
What we can do, Siva, you've done. That's a nice demonstration, and
make it bigger.
Sounds like you're going to get a transthoracic echo.
Yeah.
So when we come back to you for your next case, you could perhaps show us the transthoracic.
Transthoracic is not showing much, Neil, right now.
Your next case.
Make the picture larger, that LVOT larger. LVOT bigger. There is a small red color seen at the anterior end of the, point it out, put a pointer and show. Take the pointer inside. Yeah, in that area, but it is not looking very turbulent. And we can see the bright plug on the top. Not much of a...
You have a lot of flow masking there from calcium.
Yeah, correct. Can you make a picture
I'm sure you've reduced the leak.
In fact, in the mitral valve, the turbulence that we are seeing, we are not seeing in the aortic area. Color now again. Make the 2D gain less and then the color. No, that is the color gain you are reducing. First go to 2D. That make it darker. Yeah. Now go on color. Increase the color gains. Not much of color in the left ventricular outflow tract, Neil. Yeah, make it little broader.
Shiva, was that a
little broader.
Shiva, we're going to move on now with some of our talks. We're coming back to you with your ASD case, I believe. So a nice demonstration there and good for us all to see.
Neil, are you seeing the pictures?
The potential problem of leaflet trapping. So thank you to you and your team, and we'll see you back hopefully not before too long. Due to go back to Chennai.
Yeah.
Hello, Siva. I hope you can catch. He's got a beautiful aortogram to show us. You remember?
Yeah, yeah. Can you go live? Ready, Anju?
Into the paravalve leak. Siva, can you hear us?
Yeah.
Hear us. Sorry.
So yeah, we are able to. I'm able to hear you very well. This is the
on one of the screens. At least you can see the pre-device. Oh no, sorry. This is the.
Show the previous picture.
Post-device angiogram. Maybe
the quantum of regurgitation is less now.
130/71. So pulse pressure is around 60. So potentially some benefit compared to the 90.
It looks okay to me, Neil. It looks like it's a...
No, we think it looks definitely improved there.
Yeah, yeah.
Let's hope that the patient gets symptomatic benefit and doesn't have problems with hemolysis. So good.
Yeah.
So that's great, Siva.
Thank you.
Well done to you and your team. And we're ready to move on to your...
Next lab. Yeah, the next lab, Srija is live there. Srija?